Hodgkin lymphoma, or HL, is a highly curable form of B-cell lymphoma. It's characterized by the presence of Reed-Sternberg cells, a hallmark diagnostic feature. This lecture will explore HL's classification, staging, and treatment strategies with clinical insights. Hodgkin lymphoma is a unique B-cell lymphoma defined by Reed-Sternberg cells in an inflammatory background. It has a bimodal age distribution, with peaks in early adulthood between ages 15 and 30 and late adulthood beyond 55. While it slightly favors males, its presentation and outcomes depend significantly on subtype and stage. Hodgkin lymphoma is classified into two major categories. Classical Hodgkin lymphoma, or CHL, comprises about 95% of cases and includes subtypes such as nodular sclerosis, the most common form. In contrast, Nodular Lymphocyte-Predominant HL, or NLPHL, is distinct in its expression of B-cell markers like CD20 and the absence of Reed-Sternberg cells. Accurate staging is critical for guiding therapy. The modified and Arbor classification assesses disease spread, stage I, a single lymph node region or localized extralymphatic site. Stage II, two or more lymph node regions on the same side of the diaphragm. Stage 3, nodes on both sides of the diaphragm, possibly including the spleen. Stage 4, disseminated involvement of extralymphatic organs like the liver or bone marrow. Modifiers like A and B reflect the absence or presence of systemic symptoms such as fever, night sweats, or weight loss. Patients with Hodgkin lymphoma often present with painless lymphadenopathy, commonly in the cervical or supraclavicular regions. About 60% exhibit mediastinal masses, and B symptoms, such as fever, drenching night sweats, and weight loss, are seen in advanced stages. Diagnosis requires an excisional lymph node biopsy, with confirmation through Reed-Sternberg cells in a mixed inflammatory background. Immunohistochemistry differentiates CHL from NLPHL. CHL is CD15+ and CD30+, while NLPHL is CD20+ and CD45+. Management of Hodgkin lymphoma depends on stage and subtype. For early stage disease, IA/IIA, 2 to 4 cycles of ABVD chemotherapy followed by radiation is standard. Advanced stages often require escalated regimens like BCOP, especially for bulky disease. For relapsed or refractory disease, salvage chemotherapy followed by autologous stem cell transplant is effective. Recent advances include targeted therapies such as PD-1 inhibitors like nivolumab and pembrolizumab, and the anti-CD30 conjugate brentuximab vedotin. NLPHL is often managed with localized radiation or rituximab-based regimens due to its indolent nature. Hodgkin lymphoma has an excellent prognosis, with a 90% survival rate in early-stage disease. However, long-term follow-up is essential to monitor for secondary malignancies, cardiopulmonary toxicity, and endocrine disorders. Multidisciplinary care ensures optimal outcomes. Hodgkin lymphoma exemplifies a curable malignancy when treated promptly. As understanding and therapies evolve, the outlook for patients continues to improve. Explore more advanced topics or contact your oncology team for case discussions.